Everybody, and welcome to our meeting, the 29th meeting of the House of Commons Standing Committee on the Status of Women. Pursuant to Standing Order 1082 and the motion adopted on Tuesday, February 1st, the committee will commence its study on the mental health of young women and girls. Today's meeting is taking place in hybrid format, pursuant to the House Order of June 23rd, 2022. Members are attending in person in the room and remotely using the Zoom application. I would like to make a few comments for the benefits of the witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. Interpretation for those on Zoom. You have the choice at the bottom of your screen of either English or French or floor. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through the chair. For members in the room, if you wish to speak, please raise your hand. For members on Zoom, please use the raise hand function. And the clerk and I will manage the speaking order as we best can and appreciate your patience and understanding as we're going through this. Today, of course, we are starting a really important study that we have all talked about, and it's going to be a very exciting panel. And today, I would like to welcome our first list of guests for our first panel. Today, we have from Children First Canada, we have Sarah Austin, Founder and Chief Executive Officer, Megan Jacques, Youth Representative, Youth Advisor, Council, Youth Canadians Parliament. From Jack.org, we have Rowena Pinto, President and Chief Executive Officer. From the Centre for Addiction and Mental Health, welcome to Dr. Leslie Buckley and Chief Addictions Officer, and Dr. Daisy Singla, who is the independent scientist. As an individual today and in the room, we have Dr. Simone Vigod, Professor and Head, Department of Psychiatry, University of Toronto Women's College of Hospital. As an individual, we also have Dr. Peter Zatmari, Senior Scientist and Director of Kundal Center. And as an individual who is actually only here for the first hour, so if you do have questions specifically for this person, make sure we get it in our first hour. And that is to Dr. Charlene Zen, Professor and Canada Research Chair in Sexual Violence at the University of Windsor. What we'll be doing is providing each organization 5 minutes. When you see me frantically start moving my wrist in the air, that means your time is coming up, and I will cut you off probably within 15 to 20 seconds because we do have such an exceptional panel and so little time today. We will be doing committee business, so our questioning periods will only be 90 minutes in total today with our presentations. So to get it started off, I would like to welcome Children First Canada for your first 5 minutes of presentation.
Thank you, Madam Chair, and thank you for this opportunity. As everyone heard, my name is Sarah Austin, founder and CEO of Children First Canada. CFC is a national charity, and we are a strong, independent, and effective voice for all 8 million kids in Canada. And I'm so pleased to be joined by Megan Jacques, the chair of CFC's Youth Advisory Council and member of the Young Canadians Parliament. Megan is also a recipient of Canada's Pandemic Heroes for Mental Health Inspiring Youth Award. As a national charity that engages children and youth, we publish research, raise awareness, and mobilize action. We can speak about the mental health crisis facing girls and young women in Canada, and also about the innovative and evidence-based solutions that are needed. And we do so through an intersectional lens focused on the inequitable impacts of mental health on girls who are racialized, First Nations, Métis, and Inuit youth, SLGBTQIA+, and girls with disabilities. I also speak as a woman who has experienced poor mental health as a girl and throughout my life, and as a parent of a child who has experienced poor mental health, and as someone who has witnessed this crisis unfolding in the homes of families across the country. Our aim is to share our personal perspectives together with the evidence gathered through CFC's years of experience, doing research, youth engagement, policy influence, and engaging the Canadian public. And we bring a unique perspective on the challenges at hand. In April of 2021, at the height of the pandemic, when many schools remained closed, CFC joined with children's hospitals across the country in declaring Code Pink. It's a term used for pediatric emergencies, and we called on federal and provincial governments for an emergency response. There was an overwhelming evidence that children and youth, and girls in particular, were facing threats to their survival. Rates of suicide, depression, anxiety, eating disorders, substance use disorders, and self-harm were alarmingly high. Code Pink unleashed a tidal wave. We were flooded by calls, emails, messages from girls and youth, parents, teachers, grandparents across the country who were experiencing this crisis in their homes and who joined us in calling on governments to take action. Yet here we are over a year later, and fundamentally nothing has changed for the better. New budget commitments have been announced and promises have been made, but the reality for girls and for young women and for kids and youth more broadly remains the same. Code Pink remains in effect. In our latest Raising Canada report on the top 10 threats to children, poor mental health is the #2 threat to childhood. The data for the top 10 threats is examined through the lens of equity, diversity, and inclusion, and we can share with you ample evidence that shows that the threats to children and to girls in particular are growing. Many of the top 10 threats, such as poverty, child abuse, systemic racism and discrimination, bullying, and climate change, are known as adverse childhood experiences which directly impact the mental health of girls and young women. From coast to coast to coast, many girls do not make it to their 18th birthday. Suicide remains one of the leading causes of death for children and youth between the ages of 10 to 18. These are devastating statistics that are too alarming to be ignored. Every girl, and in fact every child, deserves the right to survive and thrive. So we urge this committee to consider the need for prevention and intervention for the mental health of girls from the very earliest days of life. Half of all cases of mental health begin by the age of 14 and 3/4 by the age of 24. We urge you to work with a sense of urgency. Every day, every hour, every minute matters in the life of a girl. And we urge you to work with girls and young women in defining the problems and the solutions. They have a right to be heard. So on that note, I cede the floor to Megan to share her perspective. Thank you, honourable members, for your commitment to address the mental health of girls, and I'm hopeful that more deliberate action will be taken in the near future.
Megan, you have 1 minute.
Thank you. I believe that society sends very contradicting messages to women. They should look pretty, but not too pretty. They should share their feelings, but not be too open. They're told that they should strive to be self-reliant and powerful, but simultaneously reminded that they are weak and inferior to men. This causes, as Sarah mentioned, an internalizing of their feelings and the negative comments toward themselves. The stigmas regarding girls' mental health as just being a teen or full of hormones or overreacting or too emotional is terribly damaging. In fact, women and girls attempt suicide 1.5 to 2 times more often than men and boys. Now, these women are not struggling. They are not weak. They just need our support to pick them back up. Just like I needed when I was told I was too sensitive rather than anxious, or too intelligent to have depression, after I tried to kill myself at 15, at 16, at 17. I wasn't asking for big changes then. I was just wanting for someone to believe me and work with me to make it better. So I'm here today asking you to take action, but also to show you that I'm part of the solution. All girls are part of the solution. As an advocate for mental health, I am leading changes in my community across the country.
Megan?
I ask the community...
Okay. Sorry, I do have to cut you off. I've let you go over a little bit longer there. We'll make sure that some of these can be asked through the questioning, okay? I'm going to now pass it over to Jacques.org. And Rowena, you have the floor for 5 minutes.
Great. Thank you. Good morning, honorable members. As mentioned, my name is Rowena Pinto, and I'm the president and CEO of Jack.org, a national non-for-profit organization with the mission of improving mental health for youth across Canada. I speak to you today from Toronto, located on the Indigenous territory of the Huron-Wendat, Haudenosaunee, and the Mississaugas of the Credit, which is covered by the Upper Canada Treaties and part of the Dish with One Spoon Treaty. Thank you very much for having me here. So Jack.org provides upstream peer-to-peer mental health education and capacity building for youth in their transition years, aged 15 to 24. We believe that the best way to improve mental health for youth is by engaging them directly, precisely because youth are in the best position to identify their mental health needs and speak to the issues they are facing. Jack.org engages thousands of young people across the country to educate their peers and promote mental health in their communities. As of 2021, around 3/4 of the young people in our network identify as young women, and 60% identify as having lived experience with mental illness or a mental health struggle. Looking at the broader research around mental health, we know that suicide has long been the leading health-related cause of death among youth in Canada. youth aged 15 to 24 experienced the highest rates of mental health distress amongst any age group in Canada. Over the past decade, and especially during the pandemic, youth are increasingly reporting worse perceived mental health. This trend is particularly true for young women who experience both higher rates of diagnosis and reported symptoms of anxiety and depression relative to young men, and have also experienced higher increases in these experiences over time. Black, Indigenous, and LGBTQ2S+ youth also experience particular vulnerability to mental health distress, even as they face greater barriers to care. The factors influencing youth mental health distress are complex. However, since beginning to survey youth in 2019, our network has consistently identified certain factors as common mental health stressors. Perceived and objective financial strain, academic pressure, and lack of employment and educational participation were raised as particularly salient mental health stressors. Youth have raised that we must not forget about stress related to minority status for equity deserving groups and the emerging stressor of climate anxiety. As you can see, the mental health challenges faced by young women and girls in Canada are prevalent, the underlying stressors are persistent, and the impacts are profound. What troubles us at jack.org is that the majority of youth do not seek help when they are experiencing mental health distress. While rates of help seeking are somewhat higher for young women than young men, just 16% of young women seek mental health support from a professional, while 32% seek informal support from friends, family, the internet, or others in their social networks. We need to pay greater attention to this persisting gap in health seeking while acknowledging and addressing the clear preference for young women to seek informal mental health support. Fortunately, there are some signs of hope. Investment in upstream youth mental health education to destigmatize mental illness, encourage help seeking, and encourage mental health literacy can ensure that young women and girls experiencing mental distress receive the help they need. Our key recommendation is to broaden federal attention and resources beyond clinical mental health services to focus on the larger mental health promoting environment.
I think you're
The
frozen,
mental
right?
health system
Okay.
where young women and girls live, learn, and work. Sorry?
You were frozen
What
just for a
this
second, but it's okay. You can. I think
Okay.
we got right back on.
Okay. What this looks like are efforts to build the capacity of young women and girls to identify signs of mental health struggle in themselves and their peers, engage in effective coping when they experience stressors, and access a range of mental health services when needed. And as we bolster their ability to seek help, we must also ensure that they are met with services that align with their needs and preferences. Consistent with youth's preference for informal support, peer-to-peer mental health services can be valuable provided that youth are equipped with the appropriate education to support one another. As a final word, too often we speak of these solutions without engaging the voices of the young people we seek to support. We recommend meaningfully engaging young women and girls in efforts to strengthen mental health supports in the way that serves them. They know what is best and what their needs are and what solutions will work for them. There is no substitute for their voices around decision-making table, and the thousands of youth across Canada who make up our network are keen to offer their insights to better support mental health for themselves and their peers.
Perfect.
Thank you.
Perfect. Thank you so much. Before we carry on, I'm going to pass it over to Dr. Leslie Buckley, but I just want to do a quick sound check because we see that you have different earpieces in, so I'm going to pass it to the clerk just for a sound check.
Yes, hi, Dr. Buckley. Would you mind just saying a few words? I'm just going to check with the interpreters if it's okay.
Yes, it's a great pleasure to be here today to present to this esteemed group. And I look forward to informing the group about substance use disorders in young women.
All right, so I'm telling you that your microphone is not properly selected. Would you mind going in the bottom left corner of your screen on the mute and unmute button? There's an arrow, and you can select the correct microphone. And then once you've selected your microphone, would you mind just perhaps bringing it closer to your mouth, and we can try that.
So I'm not sure what you mean there, but I certainly don't want to interrupt the proceedings. Are you able to hear me now?
Yes, we can hear you, but we just want to know what the choices you have to select a microphone. Because right now it seems like it's your device, the audio from your device and not from your microphone.
This is now from my device instead of my microphone.
I'm just going to wait for the interpreters to confirm if it's okay.
Is there a way that we could do that offline and I can go to the next panelist? Is that possible?
Juste une petite question, Madame la Présidente.
I just have a quick question, Madam Chair. Were the witnesses able to test their equipment before the start of the meeting, as we usually do?
But unfortunately, Dr. Leslie, she was right in between, so we had started the meeting right on time. What I'm going to do is actually ask if Dr. Buckley, if we could come back to you. What I'm going to do is I'm going to pass it over to Dr. Simone Bigod in the room, and perhaps we can work with you offside for a moment. So I'm going to get back to that for the Center for Addictions, but I'm going to welcome Dr. Simone Bigod, Professor and Head Department of Psychiatry. We're going to pass the floor over to you for 5 minutes.
Okay, thank you for welcoming me today to assist with your study on the mental health of young women and girls. Merci de m'avoir invité ce matin.
Thank you for inviting me this morning.
Medical doctor, psychiatrist, and researcher, I have spent my career focused on the mental health of women and girls across the lifespan. While there are so many important aspects to this that deserve our consideration, I see pregnancy and the first postpartum year, the perinatal period, as a crucial time for action for our young women. You may not know that perinatal mental illness affects up to 20% of Canadian pregnancies. This means that it affects up to 80,000 Canadians annually, posing serious risks to young women, mothers, and children at a crucial juncture in both of their lives. But this is also a time of great opportunity. If we successfully treat a young woman and mother's mental illness in the present, we improve not only her well-being, but we may prevent her child, her girls, her boys, her children, from developing mental illness in the future. Unfortunately, as few as 1 in 5 people with perinatal mental health issues receive the treatment they need to get better in this country, and the gap is largest for equity-seeking groups, including our Indigenous populations and our youngest women. We know what will help. A stepped care approach. For mild symptoms, low-cost interventions like trained peer support are highly effective. So our short-term structured psychotherapies, which we have shown in our own research can be delivered by non-mental health specialists like public health nurses, midwives, and even lay people. For more severe illnesses, we need to go up a step, where specialized therapies adapted for the perinatal period and medical treatments are also highly effective, and people must be seamlessly transitioned between the steps depending on their level of need. There are so many opportunities to close this 1 in 5 gap. At Women's College Hospital, I lead a Canada Foundation for Innovation, CFI-funded Women's Virtual Care Laboratory, where our CIHR-funded research is supporting the argument that virtual care can be used to complement our face-to-face services, especially important for traditionally hard-to-reach populations. We've even studied a virtual stepped care approach, where a care coordinator works with patients who access a platform we developed to help them determine which of the stepped care options is right for them and recommend specific virtual and in-person care opportunities in their communities. And then the platform automatically provides follow-up and monitoring so people don't fall through the cracks. At the end of 6 months, 3/4 of the patients in our study of this approach were better, versus only half in a comparison group who received the usual available care from the health system. In March 2022, invited by Dr. Carolyn Bennett, Minister of Mental Health and Addictions, I chaired a national roundtable attended on perinatal mental health, attended by individuals with lived experience and healthcare providers with multiple and diverse perspectives from across the country. What did we hear? We heard about gaps in peer support, lack of trained therapists, and a postal code lottery of specialized services. There are only about 10 specialized clinics across the country and a lack of consistent approaches in other places. And we heard about the fundamental importance of equity, diversity, and inclusion in any system solution. So with this in mind, I believe that the greatest impact on a national level would be to invest in the following 5 concrete actionable priorities. 1, fund community organizations across the country to increase daytime and weekend access to paid virtual and in-person peer support, allowing for targeting to specific groups such as Indigenous populations, Black and LGBTQ2S+, young adults and more. So no matter who you are across this country, you click, you phone, you go to a safe community space, and you have inclusive, personalized experience. 2, fund training of perinatal health care and lay providers in short-term structured perinatal mental health psychotherapies, so that getting your perinatal mental health care would be integrated, like treatment for diabetes or blood pressure in pregnancy, conditions just as serious but 10 times less common. And 3, fund the training of personnel for new specialized perinatal mental health teams for underserved regions, and end this Canadian postal code lottery for specialized care. To support this, invest in the technical infrastructure of these virtual stepped care platforms. They can be used nationally, by provinces, by regions to coordinate, and establish Canadian national guidelines for the prevention and treatment of perinatal mental illness, to work with the Standards Council of Canada to develop and monitor national standards. This is a mechanism to ensure a national shared understanding of what care needs to be delivered and standards against which we can measure our progress. I believe a national coordinating centre for perinatal mental health could deliver on the training and supervision required to action these initial priorities and establish a national network for sustainable education, research, and monitoring of progress going forward. Thank you so much for listening this morning. Merci de m'avoir écouté ce matin.
Thank you for listening to me this morning.
So much. Peter Shamardi, and I'm sorry, you're going to have to probably pronounce that better for me. He is going to be on here from Kundal Center. So, Peter, you have the floor for 5 minutes.
Thank you very much, and good morning, honorable members. I'm Peter Zotmari. I'm a child and youth psychiatrist and director of the Kundal Center for Child and Youth Depression at the Center for Addiction and Mental Health. Thank you so much for the invitation to present to the Standing Committee on the Status of Women. I am very pleased to see that you are addressing an issue that I and many of my colleagues see as a major public health problem in Canada. That is the mental health of young women 12 to 24 years of age and the widening gender gap in mental health, not only in Canada, but also globally. Sex and gender differences, for simplicity, I will refer to gender only, are pervasive in youth mental health. 3 disorders, anxiety, self-harm, and depression, which very often occur together in a cluster, represent the main causes of adolescent disability worldwide, as reported by the World Health Organization. Data from Ontario in 2014, the only province for which population-based data exist, estimated that up to 20% of adolescents experienced a mental health disorder, again, predominantly anxiety, depression, and self-harm. This triad of conditions shows striking gender differences, each disorder occurring roughly 2 times more commonly in adolescent females compared to males. Again, data from that 2014 survey show that 10% of adolescent girls report a major depressive disorder compared to 5% of boys, and 20% of adolescent girls report an anxiety disorder compared to 10% of boys. What is even more alarming is that not only in Ontario, but also in most high-income countries globally, rates of these 3 mental health conditions have increased over time, particularly among girls. So the gender gap for this triad of mental health conditions is not only large, but becoming greater over time. The reasons for these gender-based inequities are not clear and are likely to be complex. Some risk factors for anxiety, depression, and self-harm are more common in girls, while girls appear to be more vulnerable than boys to the impact of other common risk factors. Female hormonal changes associated with puberty have a profound effect on the developing brain, and early puberty, something that is becoming more common worldwide, is a potent risk factor for depression. Other risk factors for this widening mental health gender gap include the increasing prevalence of sleep disruption among girls and higher rates of sexual abuse and bullying experienced by adolescent females compared to males. We know that during the pandemic, Canadian adolescents reported alarming rates of worsening mental health. Statistics Canada reported that at one point, roughly 50% more adolescent girls than boys judged that their mental health was somewhat or much worse compared to the pre-pandemic times. We are likely to experience even more population-level risk factors in the future, whether that is another pandemic or the challenges associated with climate crisis. I have only to point to wildfires on the West Coast and cyclones on the Atlantic, the impact of that on the mental health of young people. The mental health of young women in Canada is at heightened risk in the face of these and other similar yet unforeseen disasters. I have two recommendations that I believe are within the federal mandate for health that might go some way to mitigate these challenges. First, young girls and women throughout Canada should have ready access to consistently high-quality services tailored to their gender, culture, and other aspects of identity. The federal government can play a role in encouraging the provinces and territories to come together and support this unified vision, as well as to advocate for a common platform of measurement-based care and outcome monitoring to ensure that gender-based inequities in mental health do not widen further. Second, Canada is the only G7 country which does not have a population-based survey of mental health of children and youth that includes repeated measurements over time. As a result, we do not have population-based data on the health, including the mental health of young people. As a result, we cannot say with confidence that rates of actual disorder or that mental health inequities have truly increased post-pandemic compared to pre-pandemic. The Canadian Health Survey of Children and Youth, affectionately known as
Dr. Peter, I am going to have to cut you off past your time, if you don't mind. I will cut you off right now, and then we'll get back into the questions. I'm now going to pass it back to the Centre for Addiction and Mental Health. Dr. Leslie Buckley and Dr. Daisy Singla, I'll just pass it over to you. You have 5 minutes on the floor. You're on mute, I believe.
Thank you so much, Madam Chair and honorable members. It's a great privilege to be able to present.
Can you just, before you get started, if you could take the microphone and actually just put it up closer to your lips, if you don't mind, kind of like what I'm doing here.
Okay, I think I've got it there.
Fantastic.
Is that
awesome.
better? Okay.
I would put it more towards your mouth, to be honest. Yeah, great. Thanks.
Thank you so much for your patience. My name is Leslie Buckley, as you know, and I'm the Chief of Addictions at CAMH, the Center for Addiction and Mental Health, and an addiction psychiatrist. I've been for many years, mostly focusing on women. What I'm going to focus on today is just the current landscape of substance use for young women and girls, and talk a little bit about why we need to worry about substance use, and again, what we can do. I'll speak about each substance separately. So initially, I'll start with alcohol. So alcohol is extremely important because we know of the significant harms that are related, whether it's accidents from falls, head injuries, etc., to legal issues, violence, crime, drinking and driving, or the important role for women and young women in sexual assault. And there's a double impact from substance use or alcohol use by the perpetrator, which is more common, and also sometimes a targeting of women who are using substances, who are more often the victim of sexual assault in that context. All this, of course, is in addition to the chronic harms that we know about to liver, cardiac, and more recent information highlighting the impact on cancer and elevated rates associated with alcohol. We know that all of those chronic harms happen faster in women. We're more vulnerable to alcohol. In terms of trends, we've seen that over the last 20 years, there has been a slight reduction in alcohol use among youth, according to the OSTUS, Ontario Student Drug Use and Health Survey that CAMH runs. But what's interesting about alcohol and cannabis as well is that although boys, we see boys decreasing their substance use. Women have not decreased to the same degree. And really what we've seen is sort of a meeting, and we've sort of diminished the gap between young women and young men. At this point, I see that I'm 2.5 minutes in, so I'm going to pass it over to Dr. Singla for her portion.
Thank you, Dr. Buckley. I hope all of you can hear me. Thank you so much for the invitation to speak today. My name is Daisy Singla. I am a clinical psychologist by training and very much a global mental health researcher at heart. I've worked in some of the most remote areas of sub-Saharan Africa and South Asia, only to learn that many of the lessons that we have implemented and learned abroad are completely applicable to our context here in Canada. As my colleague, Dr. Simone Bigot, had reiterated, 1 in 5 pregnant and postpartum women experience common conditions of depression, anxiety, and trauma. Left unaddressed, there are long-term negative consequences for the woman, her child, and future generations. In my travels and in my research, I have learned 3 key lessons to address these common problems. The first is that brief talk therapies work. Some of you may have heard of cognitive behavioral therapy or interpersonal psychotherapy. These brief talk therapies are amongst the most effective treatments in medicine, and yet less than 10% of women have access to these psychological treatments. The second is the power of telemedicine to deliver these treatments. COVID has catapulted our healthcare systems to reconsider how mental health care can be delivered. Telemedicine allows pregnant women and new mothers to overcome common challenges of finding transportation and childcare and allows for flexibility. Finally, we will never have enough psychologists or psychiatrists to address the mental health treatment gap. Thankfully, there is a growing literature demonstrating that non-mental health specialists, those are individuals without a specialized degree in mental health, such as nurses, midwives, peers, and teachers, can be trained to deliver these effective treatments. As I mentioned, all of these lessons can be applied to our context here in Canada. In 2020, we launched Summit, the largest talk therapy trial for pregnant and postpartum women in the world. We are funded by a US organization called PCORI, Patient-Centered Outcome Research Institute, which asks whether nurses and midwives are as effective as specialist providers and whether telemedicine is as effective as in-person talk therapy. Our trial is showing promising preliminary results, and the full results will be available in January 2020. The results will ultimately inform the step care model that Dr. Bigot referred to, and delivery of effective patient-centered talk therapies for pregnant and postpartum women. Today, I want to invite all of you to be a stakeholder in this exciting initiative to ensure that our results are materialized into service, and also to invest in the step care model that Dr. Bigot referred to earlier today. In sum, psychological treatments are effective. Innovative solutions such as telemedicine exist to improve access. In summary, I believe that we can do better as clinicians, researchers, policymakers, and as a society to serve the women and other populations with these effective treatments. Thank you.
Excellent. Thank you so much. And finally, for our last presenter, we have Dr. Charlene Sen, Professor and Canada Research Chair for Sexual Violence at the University of Windsor. Charlene, you have the floor for 5 minutes.
Thank you very much, honorable members. I'm Dr. Charlene Sen, Professor of Psychology at the University of Windsor and Tier 1 Canada Research Chair in Sexual Violence. I'm a social psychologist whose research focuses on prevention of sexual violence on university campuses and for younger high school age girls. I'm an expert on sexual violence prevention generally and on sexual assault resistance and bystander education interventions particularly. Your committee's work is focused on girls and young women's mental health. My testimony to you today, in a nutshell, is that unless and until we address the realities of sexual violence experienced by girls and young women and put efforts into preventing sexual violence, our country will not be successful in improving girls and women's mental health. Sexual violence creates numerous physical and mental health consequences, some of which are specifically named in the motion. But if we focus only on mental health supports, then we are mitigating harm, but not preventing more citizens from experiencing the harm in the first place. I care deeply about and want to combat all sexual violence. However, the vast majority of victims are girls and women, our focus today. Cisgender men and boys are 98% of the perpetrators of sexual violence against girls and women, and most are known to the victims, not strangers. So how big is this problem? Young women are at higher risk of sexual assault than women over 25. By conservative estimates, on university campuses, 1 in 5 women will experience sexual assault before graduation. However, research shows that 50% of the rapes that women experience occur by the time they are 18, which means we need to start earlier in our prevention efforts. In a recent study we conducted in Ontario with teen girls, we asked about their experiences of unwanted sexual contact and rape by male peers since the age of 14. For this study, male peers included boyfriends, friends, classmates, and strangers who were not adults. So these are underestimates. 1 in 3 girls reported experiencing unwanted sexual contact as a result of the guy telling lies, threatening to end the relationship or spread rumors about her, making false promises, threatening to end the relationship, showing displeasure, criticizing her, or getting angry. Almost 1 in 4 girls had experienced oral, vaginal, or anal rape accomplished with threats of force, or alcohol or drug facilitation, and 1 in 5 had experienced attempted rape. Young women also report being repeatedly asked, pressured, or coerced into sending nudes. In a recent US study, between 12 and 40% of teen girls reported sending a sexual message or image because they were pressured to do it. And we know this can have mental health consequences, especially when these images are then shared without their consent. We call this image-based sexual abuse. The physical health effects of sexual violence, including unwanted pregnancies and sexually transmitted infections, increased cigarette smoking and alcohol and drug consumption, and many others. Psychological effects include depression, PTSD, suicidal ideation, lack of sexual enjoyment, and fear. And fear of rape also affects the quality of life for young women who are not sexual assault survivors, leading them to restrict their movements as a precautionary strategy and limiting their employment, education, and recreational opportunities. Research clearly supports the need for increased resources for sexual assault crisis centers and other experts in providing trauma-informed care to survivors to address the varied physical and mental health outcomes of sexual violence. But this point is often made. I am directing your attention to the fact that prevention of sexual violence is equally important. The Flip the Script with EAAA program that I developed for women in university is an example of the impact we can have. Participation in the program reduced the risk of attempted and completed rape in the next 12 months by 50% and reduced self-blame, which is linked to worse mental health outcomes if women did experience rape. An adapted version of the program for girls 14 to 17 is being tested in a randomized control trial starting in January with Public Health Agency of Canada funds. You should know that research also suggests that providing comprehensive sex education supports prevention efforts. Sexual violence prevention takes time, resources, and expertise, and it requires dedicated investment. Thank you.
Thank you very much. We're now going to be starting with our rounds of questions. Each round for the first bit is 6 minutes. We're going to start off with Shelby Cramp. Shelby, you have the floor for 6 minutes.
Thank you, Chair, and thank you to all the witnesses for your testimony today. We can all acknowledge that growing up, there's rapid developmental changes physically and clearly very deep emotional changes that happen. And for a lot of girls, this can be very exciting. And for other girls, this is very daunting and confusing and uncomfortable. So my first point would be, why is this happening and what are some examples? And then I'll get to my actual question. So as parents and aunts and grandparents, I think we need to be watching for social cues, watching for how they're eating, how they're sleeping, patterns with their relationships with other girls, with coaches, with parents, with other adults, with teachers, with themselves, with food, with their social media. Self-esteem and body image is huge. Bullying, pressures, trends, drinking, smoking, cyber addiction. This is not news to any of you guys. In the midst of my comments, I'd like to also acknowledge Megère Jacques. I think it's brilliant that you are here speaking with us, and thank you for being open. And I agree that being part of the solution is paramount, as, in my opinion, youth are the very most important people to be talking about this. So my one question to you would be, do you feel as though there are enough youth actually involved in being part of the solution? And secondly, as taking the mom hat off and putting on the hat of the legislator, I think that there was a comment made from Miss Austin with regards to new budgets, promises made, nothing has been done. And that's the disturbing part to me, because it's brilliant that we're all here talking about it, but it's pathetically alarming if all we do is talk about it and not actually do anything about it. So my question to perhaps Sarah would also be with regards to prevention and intervention, what actual specific mediums are we using to get to these young adults and to actually help them? Thank you.
Ms. Jacques, if you want to start.
Yes, thank you for the question. I believe that there are actually more youth who are interested in speaking up and working toward better mental health, but there is kind of a barrier where we're not always trusted to take our own decision or make our own choices regarding the issue, and that's scary for a lot of teens. I was lucky enough to find an organization that was ready to listen to my voice and accompany me during my process, but not all teens or youth have that opportunity or that luck. And that's something that we should definitely work on to harness the full power of youth engagement. Because if it's too much of an effort to actually stand up for yourself, sometimes that might be a little bit difficult, especially if you have mental health issue, like a lot of youth who advocate for mental health have. For example, with my own anxiety, it was very hard to reach out to organism or just to be in a group and talk about it, because I was so anxious anywhere. So having a place that felt safe would definitely help regarding youth engagement. And I think that the Young Parliament, Canadian Parliament that we're working on exists for this very purpose. Every young girl, every young boy, any youth works together with the government to find solutions and protect our rights, because we're ready and we want to make a change. Thank you.
Thank you. And Sarah, I'm not sure how much time you have left. Okay, thank you.
First of all, thank you, Madam Chair and honourable members, and thank you to Megan for her courage and bravery today, and to many young people like her who are speaking up, asking for help. Far often we see that when young people do have the bravery to ask for help, they simply don't have that help available to them. And province of Ontario, for instance, kids can be on wait lists up to 2.5 years waiting for mental health supports. When we think about the issues and the gravity of things like self-harm and substance use disorders and suicide, to expect a young person to wait for so long for mental health supports is unacceptable. This is partly why we see such a rise in young people seeking mental health supports in emergency rooms. And again, they need to know that they can go there if they're in crisis, but they should be receiving supports within a clinical setting, within their community, within their schools. We are proud to have been able to launch the Young Canadians Parliament at the very beginning of the pandemic, and to provide young people with a platform to be heard by parliamentarians and to be able to speak up for themselves in decisions that were being made real time throughout the pandemic. But we are dismayed at how slow it has been for funding to flow, and that funding that has been announced has not often been directed at young children and adolescents. There has been funding for organizations like Kids Help Phone, which is very important, and we have commended those efforts, but other funding has been slow to flow, and so we continue to call for designated funding for children and youth to start in the early years, to start with prevention, but of course also to provide the crisis support that is needed for children. I urge and reiterate the point that was made around data collection, that we don't have systematic data collection at the federal level across from coast to coast to coast. So we're often operating on limited information around different provinces or territories or municipal level studies.
Thank you, Sarah. I'm going to have to interrupt so that we can get on to our next line here. I'm going to pass the floor over to Emanuela. Emanuela, 6 minutes.
Thank you, Madam Chair, and I'd like to thank all of our witnesses for being here with us today, especially Megan for being so brave and coming and testifying here, and on behalf of all young women that I think she's here representing today. The first question that I have, a lot of people mentioned the higher amount of attempted suicide and of, I guess, depression, anxiety that is reported in young girls. I think it's 2 to 1. That's the statistic that I heard around the table. And I'm wondering if you can let me know, based on research that you have done, whether or not that might be because boys don't necessarily come out and express themselves as much. Are we missing that part? And, apparently, according to research, there's a higher rate of suicide among young boys than there is among girls. I don't know if anyone around the table can confirm that, but if you can speak to this notion. I think that quite a few of you have kind of touched on this subject, but I think that I'm going to start with Mr. Zatmari, because I think you were the one who mentioned specific stats around the ratio.
Yeah, it's important to distinguish suicidal ideation, suicidal attempts from completed suicide. So there's no question that young girls experience suicidal ideation or make a suicidal attempt that's non-fatal 2 to 3 times more commonly than boys, and young boys do complete suicide more commonly than young girls. But what's quite disturbing is that that gender gap on completed suicide, boys completing more commonly, is narrowing over time, not only in Canada, but actually internationally as well. So gender gaps where boys are more commonly affected, like antisocial behavior, substance use, and completed suicide, that gender gap is narrowing over time, suggesting that the mental health of girls is being differentially impacted by things that are happening not only in Canada, but globally. I don't think it's a matter of reporting, because boys do report depression and anxiety, but certainly nowhere near as commonly as girls do. I hope that answers your question.
Thank you. In some ways it does. I appreciate your answer. I guess sorry, this is a hard topic for me too. I know, Megan, earlier you were giving your testimony, and I was wondering if you had anything, if you wanted to finish your comments, because I don't think you got to finish them. So if you want to take the floor, I know you already answered a question, but if you'd like to finish what you were saying in your opening statement, I'd like to give you an opportunity to do so.
Thank you. What I wanted to conclude on earlier is actually that I would like to ask this committee to really recognize girls as experts in our own lives and to respect our right to be involved in decisions that affect us. I want to say thank you to all of you also, because you've been welcoming and open to the fact that there was a younger girl sitting at this table just like you, and I think it's a really good first step toward making true change. So perhaps just to continue in that way and to listen to different girls of different backgrounds all the time in all ways.
Thank you, Megan. And Ms. Vigod, Dr. Vigod, who's in the room, you spoke about perinatal mental health problems. No doubt parenting style has a lot to do with how kids turn out and how much, how well supported they feel at home. And it affects, obviously intergenerational trauma has an effect on kids, childhood trauma has an effect on kids and throughout their life. do you think that there is enough support out there? And if there is, do you think that it is accessible? What can the Canadian government do to help support mental health across the nation? I know that it's mostly a provincial jurisdiction because it falls under health. What can the government of Canada do specifically to help the situation, to make mental health supports more accessible to the most vulnerable?
Absolutely. Thank you for the question. And in answer to your other question about the 2-to-1 ratio, right, between menarche and menopause, depression and anxiety is twice as common in girls and women as it is in men, and it's thought to be because of some of the unique reproductive issues like we were talking about related to menstruation and pregnancy, as well as because the fact that women and girls are disproportionately affected by risk factors for mental illness, as we've heard today, like violence, poverty, lack of education, et cetera. So that's what feeds into that. And as I said, unfortunately, like you said, healthy parent means healthy baby. And we talk about the years before 5 last the rest of their lives. It's actually, you need to take a step even back and say, if we can make our young parents well and well during pregnancy, that could prevent issues in children and youth mental health down the road. So when I talk about the fact that we know in Canada as few as 1 in 5 pregnant and postpartum people have the support they need, it's a big problem. What can the federal government do? So one of the things would be, for example, and this has been done before, to fund community organizations across the country to deliver peer support to specific populations, adolescents or Indigenous populations, for example. And my time's up, but I think, if I had to prioritize one thing, I would say if we could do that, we would make a huge inroad.
Thank you so much. We're now going to pass it over to Adrienne. Adrienne, you have 6 minutes.
Merci beaucoup, Madame la Présidente.
Thank you very much, Madam Chair, and thank you to the witnesses for being with us today and to talk about this issue. I agree with you, Emanuela. It's a very sensitive issue, and some of the witnesses had very poignant presentations on the consequences of mental health issues. And to be transparent, I have a cousin who committed suicide during the pandemic and is part of the age group that we're examining today. And there are members of my family who have mental health issues. And Ms. Kigo, I have a 7-month-old daughter. So the matter of mental health and perinatal depression is something that I am going through. And so it is very important for me to be here today. And Megan, thank you so much for your testimony. And before going any further, and this is something that I have experienced as an MP. Someone said, now that you are a mother and an MP, you'll feel like you're not doing enough as a mother and not enough as an MP. And I mention this because, Megan, you mentioned the double standard that women face, that young women face. Can you tell us more about this double standard and the impact on young women and girls? Answer. We always feel like we're walking on eggshells. We don't know what the good behavior is or what society expects. We want to please. We want to please our peers, adults, and we want to find a group that we belong in. But it's impossible almost to do so because from every side we're receiving different messages to be something or something else, and it makes us feel shame because regardless of how we act, there's always going to be somebody who's going to be disappointed. And we're always expected to reach higher standards as girls. This increases anxiety, but always gives us that feeling of not being good enough, that we're not doing enough, and that we don't have our place in this society. It's one of the things that is the most damaging, especially because when we try to talk about it, we're often told that it's not a matter of being a girl, but that we're just more sensitive. And our issues will be swept under the rug. And this is very unfortunate for young women. Question. I think we all agree that we need to offer more support. We need to give more support to organizations. And like other witnesses said as well, there's a lot being done in Quebec. In my riding, I'll give you an example, a community organization, and I traveled and I visited day camps. And there's the suicide prevention at Okamaska and youth homes. All told me about the increase of mental health issues and anxiety, but there are good initiatives. In my riding, there's somebody who works with the high school Wilfrid Léger, and organizations say that they need more support, and they are supported by the healthcare system in Quebec. We also have a transpartisan committee that examines the consequences of sexual assault on the mental health of women, of young girls, and we did that in Quebec. But we need to support health organizations and community organizations, and Ms. Guigaud or any other of the witnesses on this important issue, helping young girls. There are good local initiatives, but for that there needs to be more health transfers, and that's what Quebec and other provinces are requesting, 35% increase. They need the funds to help women and girls. So if any of the witnesses have anything to say, or Ms. Vigod, if you want to tell us the impact of increased funding and the impacts on prevention.
Okay, je peux répondre en
I'll respond in English if that's okay.
Thank you very much. I mean, I think that if we could fund community organizations where the people in those organizations had the ability to support their communities, we know from evidence that that can prevent postpartum depression, that can treat mild, moderate illness. And this whole conversation also really made me think about how much more we can do federally also with cross-training. If we had a national collaborative center, for example, it would be okay if there was expertise in Quebec but not in Saskatchewan, and we could cross-train. We could have licenses that went across. And I would just finally say, with respect to the other question, we talk about there was a pediatrician in the early 20th century by the name of Donald Winnicott who talked about the concept of the good enough mother. And we now talk about the good enough parent, and thinking about, it is okay to not be perfect. And that, in fact, that's what we want to do. That's the example we want to set so that people can know that they cannot be perfect and still be worthwhile and move forward. And I think, listening to all of this, I think that's the messaging we need to put forward.
Thank you so much. I'm now going to move over for the next 6 minutes to Leah. Leah, you have the floor for 6.
Thank you so much. And just want to acknowledge before I start that this is a very difficult topic for many people around the table. And thank you, Adrienne, for sharing, and Emanuela for sharing. I know that these discussions can be very painful. And I also wanted to start out with Children First Canada. Megan, thank you for sharing your truths and your story. Very powerful. And also Sarah, thank you for also sharing. I think we need to normalize talking about mental health so that we can get rid of the stigma. And so it's not based on shame, but just, telling our truths and living our truths. So my first question is actually for you, Megan. You talked a little bit about stigma, the stigmatization of young women, being overly sensitive, hysterical, all of that. How did that, if you feel comfortable sharing, did that result when you were going through mental health issues, you minimizing your own experience as a result of the minimization that was happening around you?
Absolutely. at some point, I wasn't even realizing that I still had mental health issues and I was still struggling because everyone around me said that I had to be okay, I had to pretend to be okay, I had to just smile and continue walking, doing my thing. So those stigmas are of just being too much something or not enough or something. It's always something that really puts you in a difficult place when you have mental health issue. And I would say that for me, it led to not taking care of myself as much as I would have to, and also not seeking the help that I needed because I didn't feel like I was worthy of needing help, or I didn't think that my issues were um intense enough. I was waiting and waiting for the point of like, okay, now I'm really sick because I had to be still my perfect self out of the house and even in my house. And then just my friends were always telling me, well, I feel kind of stressed too. And even too, if I was like, no, I'm not stressed. I'm very anxious right now. I have physical issues with my mental health. It's people don't realize how much what they say have power over the mind, and that point is really something that we should change amongst young girls, but uh, amongst adults as well, because even teachers at some point were trying to cheer me up and help me, but at the very basic of what their speech was indeed solely that I should just continue.
Thank you so much for sharing that. Next question I have is for Dr. Simone Vigaud. I'm glad that we're talking about postpartum depression. I know that when I was born, my mother wasn't allowed to talk about it. I know when I had my son, that was, with the public health nurse, that was top of mind, asking how I was feeling, all of that stuff. And I'm glad that we're talking about it. One of the things that you brought up, which is concerning to me looking at the Canada Health Act, is that a couple of things. One, that we talk often of provinces, except there are certain groups that are not funded under the province, particularly populations, First Nations, Inuit, federal inmates, Canadian Forces, veterans, also refugees depending on status. This is concerning because you spoke about, access, but also how it's more pronounced in remote areas. And we know that in remote areas, they had the lowest proportion of women and girls who reported very good or excellent mental health, 55.8%. So with all of those factors, particularly prenatal care and women actually having to be shipped away from families to hospitals alone for a month, how does this intensify mental health issues?
Well, I mean, the lack of access to care, and you have to also, remember that one of the biggest reasons for developing a mental health issue around pregnancy and postpartum is also lack of social support. And we could prevent it so easily with these extra, with some pretty low intensity, low cost interventions. And I think that's why I made the second point that I did, and Dr. Singla raised this as well, is that short-term structured psychotherapies can be delivered by lay individuals, they can be delivered by those public health nurses, they can be delivered in remote areas. And because of virtual and telemedicine, we can do supervision, we have ways we can help people, but people should receive care in their communities, because the other issue, as you said, is, you want to understand the experience of being a refugee or the experience of being Indigenous.
So picking up on that, the Canadian Health Act, according to that, mental health services treatments outside of hospital setting by non-physicians such as psychologists, social workers, occupational therapists, other mental health workers do not fall under the preview of the Act. The only coverage is services that are provided by a physician or a psychiatrist. So that contradicts what you just said. So do you feel that we need to make changes to the Canada Health Act to be more inclusive of service providers for people experiencing mental health issues?
You know, I am biased, but I see mental health is a medical issue and it's a health issue. So why would we deliver certain medical care and not certain other medical care?
Thank you so much. We're now going to pass it over to Michelle Ferry. Michelle, we're to our 5-minute rounds. You have 5 minutes on the floor.
Just gave me an impossible task, Chair. I need a whole lot more than 5 minutes for this conversation. Thank you to everyone. Megan, if I'm saying your name correctly, you are definitely a star in this committee. Everybody is outstanding, but you are definitely a star, and thank you for being here. I want to say into the record that we need to acknowledge that if we're going to treat youth mental health in girls specifically, that we need to be mindful that we need to invest in mental health for parents, caregivers, and men. If we are not doing this, we cannot help the young girls because, to your point, Megan, if the people around you had known how to trust you, as you've said, to empower you, to recognize your own feelings, you would be in a lot better position, I believe. I want to go right to Leslie Buckley, if I can. Leslie, do you know if there is any data on an intervention time period that determines the success of stopping addiction disorders?
Thank you so much for that question. There is, an incredible interaction between substance use disorders and other psychiatric disorders. We're talking about depression and anxiety. And we can certainly see certain relationships and patterns. So one example could be social anxiety in a young person, unaddressed, could lead at the time when people start socializing more outside of their house at age 15 or 16 to increase substance use. And that could escalate over time. So that would be one example of how a mental health issue can lead to a substance issue. But it can also happen, the other way. Sometimes somebody may be not experiencing anything from a mental health side, start using substances. Again, it's important to note risk factors for substance use are a combination of genetic and social factors, about 50-50. So somebody, everybody has a different experience with substances, and some people are much more at risk. So let's say young woman starts to develop substance use pattern, then, that may lead to certain specific events, such as maybe doing less well in school, maybe having an impact from, let's say it's cannabis, which is increasing in women. Could see that there is, an impact of increased anxiety or mood related to that cannabis. And there's been, very poor education in that realm. There's misinformation, in fact, where people think that cannabis may be helping their anxiety or their depression, but in fact, evidence shows the opposite. So, then this young person may be developing an anxiety or depression issue into their 20s and then struggling with other life events like school or relationships, which again is that spiral downward. So often we see substances and mental health issues spiraling together in that way. And, there isn't an exact trajectory. I wish I could answer your question more specifically.
That's okay. Thank you. I know there's a lot of data that I would like to accumulate, and I'm going to come back to that. If I can go to Miss Singla, Daisy, you had mentioned how we have such a huge gap and people do not have access, especially to talk therapy. Do you think there is room for modernizing healthcare to close the gap for access to mental health care? For example, especially when we're targeting 12 to 24 years old, utilizing things like social media?
Thanks so much for that question. Just to clarify, I'm also a professor and can be addressed as Dr. Singla if you wish.
Thank you.
In any case, so with regards to social media, we know that with regards to psychological treatment, the most effective treatment are those involving a therapist. And as we've emphasized, it does not have
If we could hold for one moment, there may be a problem with translation. One moment. Are you getting it?
Sure.
Okay. If we could start again on that, Dr. Singla, there was a little bit of a problem with interpretation. So if you could start that again, I'll watch the interpreters and see how we do.
Sorry, and if I can just get that fairly quickly, because I do have one more question I want to squeeze in if I can for that answer.
Sure.
Turned off the chair's mic.
Of social media. And certainly we can leverage social media to improve access to psychological treatment. But we actually have the technology available. We're using it right now to connect with all of you, presumably in Ottawa from across Canada. We can use Zoom and other secure platforms to have therapists. Again, they don't have to be psychiatrists or psychologists to deliver these effective treatments. They can be a whole wide cadre of non-specialists. We've done this around the world. We're doing it here in Canada in our summit trial to deliver these psychological treatments. And so I would very much emphasize leveraging our existing...
Sorry, I only have 20 seconds left, so I'm going to go right to Ms. Austin quickly. You called Code Pink. Fundamentally, nothing has changed. There's $45.2 billion allocated for mental health. How will that best be used, do you think, to implement action right now for mental health in youth?
If you could take that in about 10 to 15 seconds, Sarah.
I think it needs to focus on prevention and the early intervention, prevention of the mental health from the early years, looking at the effects of abuse and poverty and the systemic issues that are feeding into these to the poor mental health of girls and young women, but also the early intervention when young people are coming forward with their needs.
Perfect. I'm now passing it over to Mark Sray. You have 5 minutes, Mark.
Merci, Madame. Thank you very much, Madam Chair. And thank you to all of our witnesses. We certainly would need more time, and if ever you have any additional information to send to the committee, it would be very important to do so.
I don't really know where to start, because in Sudbury, Northern Ontario, Denise Sandul started a Crosses for Change. There's a lot of deaths of youth and individuals in the community. Minister Bennett came to visit in this summer, and we had round tables and meeting with individuals, and the conversation was around, like, I'm talking more specifically around Ontario, on the, like, there's, the conversation was like about 6,000 different organizations. There seems to be some challenge with coordination. When we look at the stats that you identified today is a massive issue, but there's still some gaps. So when we look at the federal, provincial, municipal, and volunteers, what I wanted to ask, because we heard from Dr. Weigand that the community funding is important, and I wanted to ask, maybe we'll start with Dr. Pinto and Jack Org. When we look at negotiations right now with provinces on bilateral agreements, how important that is to get this right with statistics and evidence-based that we heard earlier, and versus there's a massive urgency right now to fund organizations on the ground. Yet we have to find a way to look at best practices and with provinces. So I want to hear, I'll go down the list of witnesses, but I'll start with Dr. Pinto and maybe Dr. Buckley and Dr. Singla afterwards, about the best practices that the federal government and provinces should be utilizing when we're looking at organizations.
Great, thank you so much. I'm not a doctor, just for the record, but thank you so much. As you know, Jack.org, we engage thousands of youth across the country. And what we have really focused on is that upstream support for youth and their mental health. Because, as one of the other witnesses mentioned, there potentially is never enough money to go around in terms of accessing services. So how do we actually build a resilience and take away the stigma and improve help-seeking behaviors amongst youth? So we've really focused in on peer-to-peer support, because often that is where youth and young women especially will go to if they need help, because sometimes they don't know what services are available or can't access them. And that has been proven to help. So I would agree. I mean, the more support that can be given to organizations that actually already have an impact, already have the constituency, already have trust with different communities. I think that is definitely something that should complement whatever investment we make in the system as a whole.
And Dr. Buckley and Singla?
Thank you so much for bringing up the story of Sudbury as well, which has been, has one of the highest rates of opioid overdose in the country. I think that we can think about two clear directions, and I think that's come from this group today as well. Clear that we need prevention and we need treatment. For the treatment side, I think there'll be a lot of comments about that, and I think that Dr. Vagod spoke about having a champion group that maybe is made up of many groups that help to oversee and perhaps distribute information and supervision to community groups. On the prevention side, there's a lot that we can learn from the addiction world because we've had in some ways more experience in prevention than the mental health side has. In that it's not just enough to talk about prevention or to talk about disorders or identifying them, because we found with research in addictions that education doesn't have the impact that we thought it would. You have to have skills-based education. So you really do have to, help people understand the harms of substances, of course, but we focus much too much on that. And sometimes even just bringing up substances has actually led to an increase in substances in low-use schools, although it would reduce it in a high-risk school. So it's complicated and we have to do it right. We need to think about the centralized prevention tools that we have. So in addiction, the best is accessibility. If you increase the cost, if you have less store hours, if you have less stores, you have less substances. So that's, it's important that we know those indicators. We're not winning that political war. And I guess just my last comment as I'm closing is not to forget about addictions in the treatment that we're talking about today, because it's an important part of young women's experience.
Excellent. Thank you so much. What I'm going to do is mess around with this a little bit because I'm looking at the time. There are so many great questions still left to come. The next is going to be to the block and to the NDP. I'm going to increase your time to 3.5 minutes and then not give you a final round, just give you some additional time on that. And then we'll get the last two questions by Mike and by Jenna, if that's okay. So you'll get 3.5 minutes rather than 2.5 minutes now. And then we'll go 3 minutes to Mike Lake, 3 minutes to Jenna, and then that will be the end. Okay, so I'm going to pass it over to Christina. Christina, you have 3.5 minutes.
Merci, Madame la Présidente. Merci.
Thank you, Madam Chair. Thank you for welcoming me to your committee. I'm very pleased to be here. I am the spokesperson for the Bloc for Youth, so it is very relevant for me to be here today. I was with Miss Austin over the weekend because I was speaking to young people in Parliament, at the Youth Parliament, that are interested in democracy, and Madam Chair was there as well. I have a question for that witness, but if you have any comments, you are more than willing to give them. I would like to know what the impact of social media use is for young women. It is more and more present in our lives and the lives of millennials with the arrival of the internet, and even with TV and movies and ads, we could see the impact on body image and how that can impact what young women think of themselves and impact their self-esteem. And I believe that the pandemic made things worse, the use of social media. There are more and more studies on this topic that show that young women will feel frustration, will compare themselves a lot. And I was wondering if you see a correlation, a direct link between the overuse of social media and mental health issues that women could develop, for example, eating disorders or a lack of self-confidence.
Thank you very much for the question, and we were really honored to welcome you to the Young Canadians Parliament on the weekend and to hear from Megan and many of her peers. Certainly, excuse me, the role of social media is prevalent in the lives of girls and young women and the lives of all children and youth, even from very early stages of life. We know that young people are using technology from the very earliest days. They're playing a role in in preschool years and certainly well into their teen years. We have heard about this extensively from young people. Back in 2017, we created the Canadian Children's Charter through extensive consultations with kids from coast to coast to coast, identifying the challenges they face growing up in Canada and the solutions they envision. And they named the role of changing technology in their lives as one of their primary concerns. And it was framed in the Children's Charter as an area that they believe warrants urgent action. Again, the Young Canadians Parliament in their most recent report and in the bills that they tabled in February of this year, again, highlighted the role of technology in changing their lives and its pervasive role in impacting their mental health. Our latest Raising Canada report is full of data on this, and we'd be pleased to share that with you as well. It's extensive. It's both a problem, but also in many ways, young people also see technology as playing a role in creating the solutions that they need. We use digital technology to facilitate programs like the Young Canadians Parliament, and so we see the harms that it causes, but we also see the role that it can play in helping provide access to support. We heard from other witnesses about how technology is being used to deliver clinical services to young people and make it accessible to them in their homes or in their schools or other places where young people need support. And we need to continue to fund those innovative and evidence-based solutions to ensure that they have access and have them at the table when decisions are being made around how to deliver these services. Megan and many others want to be able to have a role in policies and programs being delivered for them.
Thanks so much, Sarah. We're now going to move on to 3.5 minutes to Leah. Leah, 3.5.
Thank you so much. I have a very brief amount of time and 2 questions. My first question is for Madame Pinto. You spoke about climate anxiety and the impact that it is having on youth. This is, I know that in the DMSI or something, I'm not a psychologist, that's actually one of the categories that they're looking at in terms of mental health stress on youth. And I'm wondering if you can expand on that. I just feel that as legislators, we're a disaster zone in terms of dealing with the climate crisis, and we're leaving an unlivable world for young people. Can you please expand on that?
Sure. Well, as everyone knows, we're confronted with the climate change situation every day. Most recently in Nova Scotia and the Maritimes just over the weekend, and I think this is having a huge impact on youth, and it's coming out. We're seeing youth take to the streets around climate change, and we're seeing that in many cases they're demanding a place at the table. And I think that really is the crux of all of it, is that we're potentially leaving all of these issues that are going to have the most effect on youth, but we're not actually bringing them to the table as part of the decision making. All of you have seen how amazing it has been to have Megan here, because she is such a strong voice and she knows what she is talking about. We can do that more. We have thousands of youth.
Thank you. Sorry.
We would like to
thank you.
bring them in.
Thank you so much. I just have one last question for Charlene Sam. You spoke about how we will not improve mental health of young women and girls if we don't deal with sexual violence. And you indicated that one of the ways to address it, you spoke about the importance of sex education. I'm wondering if you can expand why that's critical.
Yes, thank you for the question. There's a couple of ways. One is that we know that without comprehensive sex education, which most youth actually do not have, most adults have not had, we are not talking about the important issues around our sexual rights. We're just talking about bodies and anatomy and those kind of things, which are not what we need as tools to go into relationships or tools to go into the world and actually interact with people who are attempting to get us to do things that we may or may not want to do, or even to initiate sex we do want. And so we know that that is sort of a foundation. And without that, really, we're limited in what we can prevent. And it's possible to do that really well. We know from research from very young, starting like with really young, developmentally appropriate, and then expanding. And so that is a foundation. And in fact, my program, which is the only university-based program that actually shows substantial and sustained decreases in sexual assault, has a 3-hour emancipatory sex education unit as part of it. And we think that it really helps with the verbal resistance, with response to verbal coercion. Knowing what you want is a foundation for then being able to deal in the world with all of these kinds of attempts to get girls and women to do what they don't want.
Thank you so much. I'm now going to pass it over to Mike Lake. Mike, you have 3 minutes.
And I have a lot of friends on this panel, people that I know very well and respect so much of your work. Rowena, I've had the chance to work with Jack, and I was just down at the UN General Assembly and talking a lot actually with others about the incredible resource that you have with the BeThere.org website. And I'm just wondering if you could explain a little bit about that partnership you have with the Lady Gaga Foundation and BeThere.org.
Sure, thank you. Yes, we put together a certificate program that really is could be done completely online. It's called BeThere.org, and it's about a 4-hour online program where we can ask young people to actually go through the program, or other people who have young people in their lives, and it not only teaches you to identify when you are undergoing some mental health struggles, but also how to support people in your life. So I think Megan mentioned so many times she went to her peers and they didn't necessarily know how to respond to her. This will actually walk you through. There's role-playing exercises. And at the end, we actually do see that there's uplift in terms of mental health literacy, as well as people felt more confident in terms of supporting people in their lives. And this is a partnership we have with the Born This Way Foundation, Lady Gaga's foundation. And up until now, we have we launched it just a few months ago, but about 10,000 people have completed it. And I really do recommend all of you who have young people in your lives to really look at it. It's a great online program. Thank you.
Reinforces, I think, what Dr. Singla and Dr. Vigo were saying about sort of peer support and those kind of things. As we're having this conversation, one of the things that just jumps out at me is that these are issues that we talk a lot about here right now, and I think my concern is, that we have these great conversations. We have fantastic witnesses here. We're doing a lot of talking, but the reality is there's very little action. I look at during an election campaign almost a year ago, all parties had significant initiatives put forward on mental health, but the party that won, the Liberal Party, promised $4.5 billion for a Canada mental health transfer. 800 million of that, over 800 million, 875 million was to have been delivered by now, and hasn't been. We're a country that is spending more money than we've ever spent by far, and yet we still can't find the money to deliver on promises that were made in an election campaign a year ago. How much would that $875 million, how much of a difference could that make if that money was invested by now, as promised?
You have about 15 seconds, please.
Anyway. Dr. Vigo? Sure.
Listen, I think it would make a huge difference. I think that the federal government could fund specifically these coordinating centers to get everything on board, to get the standards going so that we could monitor and really making sure that we're doing a good job. And the bottom line is it could fund people, because we still need people to treat people, whatever level they're at.
Thank you very much. I see we have other hands up, but I will let you know we're coming over to the next 3 minutes, and I'm passing that over to Jenna. So you may be able to respond to Jenna's question, but I'll pass it over to Jenna for the next 3 minutes.
Terrific. Thank you very much, Chair, and thank you to all the witnesses for the incredible work you do every day and sharing your expertise with us today. You know, as we've heard a lot today, this is a difficult topic and one that I know is touching so many young people and women across our country. I think we've heard again and again from our government that mental health is health. And it's important as we move forward, continuing the dialogue with the provinces and the territories to ensure that we move forward collaboratively and we make the progress that I know we all want to make. I'd like to go back to Dr. Singla, if I may. You had mentioned in your testimony that there are not enough professionals to meet the needs of young women who are seeking mental health support. And I'd like to dig on that a bit because we haven't touched on that today. And I'm wondering if you can elaborate, is this a problem with retention? Is it training, opportunities? I'd love to hear your thoughts on that.
Thank you. I hope you all can hear me. This is a problem, this is a multifold problem where we simply do not have enough people in Canada, in the world, due to training, due to a lack of individuals who are available to deliver these effective interventions. The good news is that we don't need folks like myself or my colleagues on this panel to deliver these effective psychological treatments. We have shown time and time again in all corners of the world that individuals without a specialized degree, that is peers, lay providers, nurses, midwives, teachers, they can all be supported, they can all be trained to deliver these effective treatments for conditions across youth and across the perinatal period. Investing in non-specialist providers will allow us to have a return. If every dollar invested in this initiative would allow for a return of $3 in savings to your healthcare systems, as well as to work productivity. And these are data that have been accumulating for the last 30 to 40 years. Here in Canada and across the US, we are implementing non-specialist delivered psychological treatments led by nurses and midwives, and I'm quite confident we will show that they are as effective as psychiatrists and psychologists delivering the exact same treatment.
Fantastic. Thank you so much. We have actually come to the end of the panels for today. I know we have had some expertise on here and absolutely not enough time. So on behalf of the committee, I would really like to thank Sarah, Megan, Rowena, Leslie, Daisy, Simone, Peter, and Charlene. Thank you so much for bringing your voices here. I'm sure there'll be more conversations coming out because I've written you all down to say, I need to learn more from these ladies and gentlemen. So thank you so much. We are going to now suspend for a few minutes and go into closed session. So if we could just suspend, we'll be coming back.